Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through part two of infectious disease pharmacology. In the first one, we discussed bacterial pathogens, antibiotics, antibiotic resistance, and now we're going to go through the second part of all the other pathogens. So let's refresh one key point from that first video, and that is when a patient has an infectious disease, meaning that they are being made sick by a pathogen, a prion, a protozoa, fungi, virus, bacteria, we need a medication that will specifically target that pathogen. Whether it's a bacteria, they need an antibiotic. If it's a virus, they need an antiviral. We mentioned in that first video that there's no crossover. If a drug works for viruses, it doesn't help for bacteria. If it works for protozoa, it doesn't help for viruses, and so on. So now we're going to go into the second part and talk about all the different pathogens other than bacteria and antibiotics. We're starting with vaccines. A lot of the vaccines we have, in fact, we have vaccines for viruses more than anything else, which is why we're discussing it over here in this second part of the video. There are a few different types of vaccines. We have the live attenuated, which is a relatively common one. A lot of you nursing students have taken this for your MMR or your varicella. We have our inactivated ones, which is probably one of the most common ones used. That's for influenza. We have recombinant ones, such as the ones for the pneumonia vaccine and the hepatitis B vaccine. We have mRNA, which became very famous back in 2020, 2021 because of the COVID-19 vaccine. And then we have toxoid vaccines, such as, or really stereotypically, the one that we talk about the most is going to be your Tdap. So those are 5 different types of vaccines. Some books only count 4, some books have a few more, but that's the way I'm breaking it down for you guys. The pathogen, it's explained over here, and the examples are explained. I'm not going to go any more deep into this, just to give you a basic understanding. Vaccines are always given, almost always given parenterally. There are very few exceptions I'm not going to go into. As far as we're concerned, they're all given parenterally. When a person has a bad reaction to a vaccine, it is mandatory to be reported by you or another healthcare provider on the case. And that is reported to a joint hotline that's run by the FDA and the CDC. It's called the Vaccine Adverse Event Reporting System. Some vaccines require boosters. Very famously, the Tdap vaccine requires one every 5 to 10 years. The influenza vaccine is every year, things like that. Influenza vaccine, we don't actually call that a booster because each year we're giving you slightly different ones compared to the previous years. But tetanus is considered a booster. That's going to be our classic example. Next, there is something called the vaccine schedule. In RN school, you should be familiar with this. If you move on to NP or MD school, this is something that you may have to memorize if you're taking care of pediatric patients. This does get updated on a regular basis. So here's the one from this year from 2025. Some vaccines require multiple doses, and as you can see on here, how we give the doses, there is a supplemental chart to this that has catch-up doses if someone didn't get them as they are dictated over here for the different age groups. Remember, it is part of your responsibility as an RN to ask your patients about being up to date on vaccines and also to educate your patients on the importance and safety, above all, of our vaccines. Let's go into the medications, and we're going to start with fungal medications. So we have the azole antifungals. So the drugs over here are fluconazole, miconazole, ketoconazole. These drugs interfere with specific fungal activity that are necessary for their ability to survive and thrive. The indications for these are candidiasis, which is going to be your most tested on fungal infection in nursing school, as well as some other fungal infections. These drugs do have a few different adverse effects, such as cardiac and blood effects, skin conditions such as SJS/TEN, which is Stevens-Johnson syndrome and toxic epidermal necrolysis, as well as causing hepatotoxicity. Ketoconazole and miconazole are available in several different formulas as over-the-counter, sometimes for yeast infections of the vagina and other areas. So this is something that might be available both over the counter and by prescription. High dose ketoconazole is used for something totally different than a fungal infection. We discussed it in the endocrine lecture. It's used for Cushing's disease. And the azole antifungals are not recommended in pregnancy. I'm not saying they're teratogenic, but they're not recommended in pregnancy. Next, we have the Polines. This drug over here is really just amphotericin. And this is a very complex drug. We only use this for severe systemic fungal infections. It has a lot of issues with it. It can cause nephrotoxicity. It can cause hematologic issues. There's also something called infusion reaction that a lot of patients get with this that has fever, chills, nausea, and headache. This has a black box warning, a really interesting one, that it's only used for severe systemic fungal infections. It shouldn't be used for anything less than that. There is another drug that's technically a polyene, and that is nystatin. Nystatin is a much more subtle antifungal medication. This we use on a regular basis. both topically and via oral suspension or oral rinse. And this medication is used for oral candidiasis as well as a few other fungal infections that patients may develop. And that one does not have that black box warning that's only for severe systemic fungal infections. That's only amphotericin. Next, we're going to move on to viral infections. Viral infections very often are what's called self-limiting, meaning they go away on their own. There's a famous quote we have in infectious disease: I could give you a medication and it'll go away in a week, or don't take the medication, it'll go away in 7 days. It's the same thing. A lot of these things go away on their own. But for the ones that don't necessarily go away on their own, we do have medications. So let's get to our antivirals. We have Acyclovir, Valcyclovir, there are a few others. These suppress the synthesis of viral DNA. It's the only drug that does that exact thing. It suppresses the synthesis of viral DNA. We use this for herpes. We use this for varicella. These drugs do have GI effects. It is important to know that there is no cure for herpes, for varicella. However, this does reduce the symptoms and hopefully resolve the symptoms quicker than they would without medication. These drugs should very importantly be taken within the first 72 hours. Now, I am going to tell you one thing that's a little bit beyond what you would have to know at the RN level, but when patients have an outbreak of shingles, if they miss that 72-hour window, the medication is not going to help. However, if they had a new outbreak and now they come back and now they're within 72 hours of that second outbreak or third outbreak or fourth one, eruption is what we call it in shingles, this medication would be appropriate and effective at helping them. The next antiviral we have is oseltamivir. This is another drug within the antiviral class. This is commonly known as Tamiflu. This is a prescription medication for influenza. This is one that is a little bit debatable in primary care about how much we use this. This medication, the evidence shows it reduces the duration of the disease for up to 24 hours. Some of it has it even less than that, closer to 12 hours. So you're really just buying yourself a few hours less of being sick. That's the whole benefit to this. So for a lot of patients, it's really not worth it to take it. However, it does work. It is safe. But again, it doesn't give you that much benefit from it. This medication, like the other antiviral, also does need to be taken in a specific time frame. In this case, it's actually within 48 hours of the patient developing symptoms. Next, we have our drugs for HIV and AIDS. I want to start with a few things. First of all, I'm not going to go too deep into these drugs. There's a bunch of them. And I'm going to talk at the end a few key concepts that covers all of these drugs, but there's not going to be a ton that we're going to test on about the HIV medications. The first class of drug we have is the NRTIs. The drug over here is tenofovir or zidovudine. These drugs suppress the synthesis of viral DNA. You saw that earlier with the antivirals. Again, this is one of the ways we treat viruses is by suppressing the synthesis of viral DNA. What do we use this for? For HIV and hepatitis B. And it has a black box warning that it can cause hepatotoxicity, lactic acidosis, and steatosis means fatty stools or fat buildup in the liver, which can cause fatty stools. Zidovudine specifically has a black box warning that it can cause myopathy and bone marrow suppression. The side effects of these are extensive: SJS, 10, hematologic, cardiac, and more. Next, we have the NNRTIs. These, again, suppress the replication of viral DNA. The indications for this are HIV. And again, they have extensive adverse effects. This one is not recommended in pregnancy, and this one should be taken at bedtime and on an empty stomach. Again, we love testing on patient education and pre and post assessment, patient assessment. So because of that, I put that in there. Otherwise, I'm really keeping these to a minimum here. Protease inhibitors, we have ritonavir. This prevents the HIV from maturing, the human immunodeficiency virus, the actual virus from maturing. The indication for this is obviously HIV. And again, we have a whole list of adverse effects. All of these are really powerful medication. They mess with a lot of different things, and therefore they have some significant side effects. Finally, the last one we have are the ISTIs, the integrase strand transfer inhibitors. The drugs over here are ritelagravir and dolutegravir. No clue if I pronounce those correctly, but these interfere with the integration of HIV into DNA, which can hopefully reduce the overall HIV. The indication for this is obviously HIV, and the side effects, these are relatively minor: insomnia, fatigue, and depression. The next drug I want to talk about, which is a little bit more likely for you to get tested on, is what's called commonly known as PrEP, pre-exposure prophylaxis. And this is where a patient takes a medication before they're ever even exposed, and certainly before they're actually sick. This is very rare, and this is one of the only times we ever do this in pharmacology. The other case being, let's say, malaria that we're going to talk about later in this video. But usually we treat a disease once a patient has a disease, or sometimes, like in the case of TB, tuberculosis, we'll treat a disease once they've been exposed to it. But now we're treating a disease even before the exposure, pre-exposure prophylaxis. The drug over here is tenofovir and emtricitabine. The brand names are Truvada or Descovy. These drugs do have a side effect of decreasing bone mass and kidney injury. What do we use this for? We use it for the prevention, the pre-exposure prevention of HIV. So patients who are at risk of developing HIV for whatever reason, they take this on a daily basis and it dramatically reduces their risk of ever contracting HIV. Keep in mind, this doesn't protect you from any other STI. Next, this does require a patient to get routinely tested for HIV. Why? And first of all, how does that work? They get tested roughly every 90 days for HIV while they're on this drug. They also happen to get tested for their kidney function every 90 days because this can mess with their kidneys. But aside from that, they're going to get tested for HIV every 90 days because if they actually have HIV, this medication is not appropriate. This is two medications. They need to be on more to fully treat HIV. And we're going to learn in just a minute. I'm going to say it now. If a patient has HIV, they're going to be on multiple medications. If they do not take their medications exactly as prescribed, they're going to very quickly build up a resistance to those medications, and those medications will no longer work for them. However, if they take their medication every single day for the rest of their life exactly as prescribed, generally speaking, in most patients, we are able to fully manage the disease, prevent transmission, prevent sequelae, which means further development of complications of the disease. We have very good treatment for HIV today with medications, and there's even more than what I put on here. However, it is incumbent and dependent on the patient fully following the directions and taking exactly as prescribed, which brings us back to why does this require HIV testing? Because if they have HIV, they need to be on more medications, and being on just these two would be sort of counted as they were supposed to be taking more and they weren't, so they were non-compliant, so they were so the disease can become more difficult to manage. However, because we do routine testing on these patients, as soon as we do see that they test positive, if they do, we immediately get them started on the full medication. And that's the concept behind the routine testing, and it works very well. These drugs do have a black box warning that they can make HBV, hepatitis B, worse. And again, like I mentioned, it can lead to that medication resistance. Here are a few just good notes for HIV treatment and some of the more tested on aspects in pharmacology. Most patients are going to be taking multiple of these medications, such as NRTIs with a PI, and there's tons of different combos. I'm not even going to get into that. It is critically important that patients are educated to never miss a single dose. You miss as much as just a few doses in your whole life, and the medication may no longer work. When we're assessing a patient for the efficacy of our treatment for HIV, we're checking two labs. We're checking the CD4 T cell count and the HIV viral load, HIV RNA. The HIV RNA we want to be down, and the CD4 T cell count we want to be up. The terminology ART, antiretroviral therapy, refers to all the drugs that treat HIV. These drugs are continued for the rest of a patient's life. And like I said, with proper treatment, HIV is fully manageable nowadays. So if a patient it's caught early and they stick to the medications, they otherwise stay healthy. These patients have, if I'm not mistaken, nearly equal lifespan as someone who doesn't. Healthcare workers may sometimes be exposed to HIV through an eye splash or a needle stick, something like that. In those cases, you may get put on prophylactic treatment. It's completely dependent on what the situation is and how bad the exposure was, for how long the medication is going to be, and what medications they will be. Next, we have the anthelmintics. Helmintics means worms, and the drugs over here are ivermectin and mebendazole. This drug works by increasing cell permeability so that the cells leak all their content out and therefore the organism dies. We use this for worms and for other things like that. Next, we have the anti-malarial drugs. The drugs over here are chloroquine and hydroxychloroquine. Hydroxychloroquine became a little bit famous a few years ago back during COVID. The mechanism of action here is that it takes multiple actions against malaria. You don't need to know any more than that. This is a rarely tested on drug. Even post-COVID, the indications for this are malaria treatment and prevention. The side effects, there's a bunch of them: cardiomyopathy, hypoglycemia, myopathy, and other issues as well. Patients should be educated to avoid exposure to the sun if they are taking this medication, and this is the first-line treatment for malaria. This is the other one that I mentioned about 10 minutes ago, that sometimes patients will be prescribed this, not even when they have the disease, not even when they were exposed to disease, but before they're exposed. This is commonly given for patients traveling to areas that malaria is endemic, and they start taking it even before they get on the plane. Next, we have metronidazole. Metronidazole is famous for one reason, and that is this is the only drug in all of infectious disease, at least that I'm aware of, that treats two different types of pathogens because it works against both protozoal infection and bacterial infections. I said in the beginning of this video, in the beginning of the other infectious disease video, that no drug works for multiple different types of pathogens. Of course, there's an exception, and this is it. The drug works by impairing DNA function, and like I said, it works for protozoal infections and bacterial infections. This is our go-to drug for trichomoniasis, which is an STI caused by protozoal. It does have a bunch of off-label uses. We often use this in the hospital for infections that we're still trying to figure out exactly what it is while we're waiting for some tests to come back. It does have some significant adverse effects, such as that SGS-10 that we keep talking about and blood disorders. This medication is commonly tested on the fact that you absolutely cannot take this with alcohol. If it is mixed with alcohol, it's similar to mixing and abuse with alcohol, and the patient can get really, really sick very quickly. So make sure you educate the patient to avoid alcohol. This does have a black box warning that it is found to be carcinogenic in animals. Next, we have an anti-infective. I've never seen this listed in a nursing pharmacology test bank, but it is in all your books, so it is fair game. The drug is bacitracin, which most of you are probably familiar with. It inhibits bacterial cell wall synthesis, which we talked about way in the beginning of video 1 on infectious disease when we talked about antibiotics. That was the most common antibiotic mechanism of action. This one works by preventing bacterial infections. It doesn't treat any bacterial infections. And this is applied topically to whatever area is at risk of an infection up to 3 times a day. This also has an ophthalmic option and a systemic option. Lastly, we have the pediculate side. This is going to be permethrin and pyrethrin. And these drugs are available, some by prescription, some over the counter. These kill lice and scabies. The directions very specifically, and you should know these. For scabies, the entire body should be covered except the mucous membranes, and they should be left there for 8 to 14 hours, so overnight, and then you clean it off, and that's meant to kill all of it. For lice, wash the hair first, then put the medication into the hair, leave it there for at least 10 minutes, then wash it out, and then at that point, use a comb to get rid of all of the lice. I spoke too soon. Lastly, we have the immunosuppressants. Immunosuppressants is completely separate from everything we've been talking about up until now. This is meant to suppress the immune system, and the drug over here is cyclophosphamide or cyclosporin. A bunch of the monoclonal antibodies are also used as immunosuppressants. Steroids are used as immunosuppressants, and these work through many different methods, all of them geared towards suppressing the immune system. What will we do this for? We would do this for cancer, we would do this for post-transplant patients, and we would do this for patients with autoimmune diseases. The side effects depend on which of these drugs we're talking about, and all of these drugs are discussed, the monoclonal antibodies and steroids are both discussed elsewhere. The other two, there's not a ton for me to cover on this. Just know these basics, what they're used for, and always, if a patient's on an immunosuppressant, educate them to immediately report a fever, to avoid contact with anyone that's sick, possibly to wear a face mask if they're going around other people, etc. If you have any questions, please reach out. Here are the references. Please like our video, subscribe to our channel, and have a great day.